So welcome, my name is Terrence Keeney, and welcome to the GWU Dermatology Translational Science Lecture Series at George Washington University. I want to thank Sun Pharma for their sponsorship for this excellent program, and it is my pleasure to introduce Dr. Robert Kirsner, my former professor and mentor at the University of Miami. He is the Harvey Blank Chair of the Department of Dermatology at the University of Miami. He is a fellow college athlete. He was a basketball player at Texas A&M. I was hoping to have a photo of him in his short shorts. I think all those have been scrubbed from the internet. He went to University of Miami Medical School and stayed there for his residency, and for many years, and still ran the wound center there. And a couple of years ago, was elevated to the chair position. During residency, Dr. Kirsner was the guiding force, within our department, the intellectual force. If anything he said at a grand rounds, once he, spoke up, which was, he wasn't the most boisterous, but when he said something, it was very valuable and everyone quiet and in all discussion. So it's really an honor to have him here. He's a world expert in wound care with, hundreds of publications, many books. And he'll be speaking on it today. So it's truly an honor to welcome Dr. Kirsner to the DC area. Please give him a hand.
Okay. Well, great. Thank you so much for inviting me here. It's great to be here. And I'm going to try to make this a practical talk for dermatologists. Because I know that oftentimes when you hear wound care, your eyes roll over and you say, oh, geez. But we're going to try to avoid that. As Terrence told you, we both hail from the University of Miami. This is the center of the medical complex. In the background is the big county hospital, Jackson Memorial Hospital. In the foreground was the original hospital, which is now kind of a museum called the Alamo. But you don't get the sense of the medical center just from this picture. That arrow points to where the medical center, where that picture was taken, and the big circle is where the whole medical center is. So it's quite large. It's one of the largest in the country. If you look at the very top of the screen, you'll see downtown Miami, then Biscayne Bay, and then at the very, very top, Miami Beach, and then the Atlantic Ocean. And we're a fairly large dermatology program. We have 31 full-time faculty members. We have 24 residents and 21 fellows in the department. So what I want to do is I'm going to use a few questions just to talk about some concepts or ideas around wound care. And the first one is that you perform a large surgery and the patient is worried about postoperative pain. And the question is, would you prescribe opioids in case they experience pain? So that's the first question I want to ask you and let you think about your answer, yes or no. And the first kind of pearl I would like to share with you is that although it turns out some recent data, about 60% of dermatologists prescribe opioids after Mohs surgery, it turns out you should try to avoid opioids. Okay? And it seems kind of obvious, but we know that there's an opioid epidemic, that up to 8 million Americans take opioids, and there are a lot of side effects. There's adverse side effects, there's tolerance, addiction, death, and to all these famous people recently died from opioid addiction. And I didn't update this slide, but I should add Tom Petty to this picture as well, who also died from opioid overdose. And both prescription and illicit use of opioids have been on dramatic rise over the past number of years. So there are lots of good reasons to avoid opioids. But another good reason to avoid opioids, which I'm going to tell you now, is that opioids impair healing. Okay? We looked at a database. We performed a large trial of venous leg ulcers. Actually, it was a multi-center trial in both US and Europe. We looked at 715 patients were followed exquisitely for 12 weeks. The treatment that was being studied didn't work, but we were able to analyze the data for that. And we looked at lots of different medications to see if any medications might have impacted healing. And we looked at a bunch of these medications that may impact healing. And what we found that of these, only opioids had an effect on healing. Okay? And it turned out that about a third of patients with chronic wounds, with venous leg ulcers, were on opioids. So 1 out of 3 patients were on opioids. And what we found was that the patients who are opioids were less likely to heal. Okay, so we thought about it and said, well, maybe it's because patients who have venous leg ulcers, maybe if they're larger, they're on opioids. Or maybe if they've been around longer, maybe that's why they're an opioid. So it had nothing to do with the opioids. It was just that patients who had worse venous ulcers got the opioids to take care of them. And it turns out that when we controlled for things like area and duration, things that are known to affect healing, that the opioid still remains statistically significant. That non-closure of venous leg ulcers was related to larger wound area, longer wound duration, to being a man, and to the use of opioids. Now, this data has also been confirmed recently by some work actually at Georgetown University at their wound center, where they looked at a cohort of patients and looked at opioid usage, and across different wound sites in a real-life population, not in a clinical trial population, opioids were associated with non-healing, and the higher the dose of the opioids, the more likely a patient was not to heal. So this seems to be a real phenomenon. Now, the reason for that is not entirely clear. We don't know why. It could be behavioral factors, could be biochemical factors. The easiest way to think about it is that the opioids opioids bind to opioid receptors, and they reduce the release of substance P. And by inhibiting substance P may be a detrimental effect on healing, because there is experimental data that substance P benefits healing in experimental models. It modulates inflammation, it stimulates mesenchymal stem cells, it does a lot of important things in healing, and the simplest thing is that by taking opioids, you block release of substance P, and that may be causing the non-healing. But there's lots of other things that may be at play. Opioids decrease immune activation, they impact oxygenation and angiogenesis, they alter myofibroblast recruitment and keratinocyte cytokine proliferation, decrease endothelial proliferation, and in animal models and in experimental models, naltrexone, which blocks one of the opioid receptors, actually accelerates wound healing. So there's enough basic science data here and clinical data to suggest that if you can avoid opioids, you should. And this is the data, I think, from Georgetown University, showing that in a real-life population, that it's better off to not be on opioids than to be on opioids. So what do you do for pain? Well, it's a tough problem, and probably in the next few years, we're going to find novel ways to treat wound pain. This is a case series of patients who were given topical cannabis for wound pain. And this is a new chemical entities that don't have the psychogenic effect on patients, but may work to reduce wound pain by other mechanisms. So this is something we should keep our eyes out for. So first pearl is avoid opioids if possible. The second question I'm going to ask you is that you have a patient with a chronic wound and you want to do a skin graft. And the patient asks whether the donor site that you're going to harvest the skin graft from, will it scar? So is the answer yes, no, or it depends? So the second pearl I want to share with you is the idea of scarless donor sites. Scarless donor sites. And this is a traditional skin grafting. This is something we've done for a long time. We can do it in the operating room. We use this device called a dermatome. There's a little button there. You set the thickness so you can't go too deep. You take a sheet of skin, then you put it through a machine on your far right called the mesher. That mesher makes it a little bit larger and creates interstices. And when you put it on a chronic wound, that way fluid and exudate can escape, and it doesn't lift up the graft if there's any fluid there. But the problem is that you're taking partial thickness skin or split thickness skin, and it will lead to a scar. It does help heal chronic wounds. For example, this is just a patient. We've published on this over the number of years. This is somebody with a chronic non-healing venous leg ulcer treated with a mesh split thickness skin graft, and you could see not only did the wound heal, but the areas that weren't grafted actually healed as well. So you don't have to graft the whole thing. You could graft part of it or most of it, and you still get a beneficial effect. Patients like skin grafting. Why? Because they heal faster. And there's in both social functioning, mental health, quality of life, all quality of life measures. If you heal patients with skin grafting versus not skin grafting, patients prefer that. But there are these donor site disadvantages. You leave a scar. There's anesthesia required. Sometimes if you have to go to the OR, which is expensive, you create a second wound, and not only will it scar, it can be painful, it may cause infection. You have to, the time and cost of the procedure. And very importantly is that for many of these chronic wounds, they recur. You have a venous leg ulcer, you treat it, you heal it, a year later they get another one. So you graft again. A year later they get another one. 20 years later, their thigh looks like a checkerboard because of all these procedures. So are there any ways to get around these donor site morbidity? Well, one way is simple grafting. You know, could be done at the bedside. Very cheap, very inexpensive. Anybody could do this this afternoon in their clinic. It's called pinch grafting or punch grafting. And basically, this is all the tools you need. You create a little wheel. You shave off the wheel and then put a piece of skin on a wound. Here's a chronic venous leg ulcer, almost like taking a shave biopsy. You could use an 11 blade. You could use a derma blade. You take a piece of shave, put it onto the wound. And even if the grafts don't take, here, by transporting healthy skin onto a chronic wound, you supply that wound with cytokines and growth factors that will take a previously non-healing wound and make it go on to healing. Very simple procedure and less expensive, less involved, but you still have donor site morbidity. And this is just an example. This lady came to me. She had broken her arm, went to the ER. They told her to put an ice pack on it, and then they didn't tell her to take off the ice pack. So she got a burn wound, a freeze burn on her arm, and we debrided it, but she had a broken arm, and the surgeon wasn't going to fix the broken bone until the wound healed. So we had to get this thing healed very quickly. So we decided to do a little pinch graft, just like I told you. And in this case, we used a derma blade to put it on. This is the donor site. She did quite well. You know, here you could see from the day of grafting, day 8, almost completely healed. By day 21, certainly healed. Day 35, completely healed. Pretty fast, very good. And you could see that the donor site healed almost as fast or as slow as the recipient site. And not only that, you see that even though this is a super simple procedure, you still leave a scar and a mark. So while this is fast and simple, easy, there's still donor site morbidity. So the question is, can you skin graft without or with even less donor site morbidity? And the simple way to do that is to take just the epidermis, epidermal grafting. So if you take just the epidermis will regenerate without a scar. So how can you do this? Well, if you can do this by adding suction or heat to the top of the skin, create a suction blister that will separate the skin in its weakest point, which is the lamina lucida, and then you could take that skin and harvest it. Prior to the development of this device, which is called the cellutome, and I don't have any commercial interest in it, cellutome, you had to use suction blisters, which were complicated and difficult. But this device, which was manufactured a few years ago, allows you, without any anesthesia locally, you put this on, you get these little microdomes in about a half an hour, that you hit a lever, and you could transfer that epidermal grafts onto a dressing, and then apply the dressing onto the chronic wound. And you could see the donor site, no morbidity. That was the pinch graft that I did earlier, and these are 3 different patients immediately after the grafting procedure. You can't even see the mark. And by dermoscopy, they heal in 2 days. By confocal microscopy, they heal in 2 days. So no scar, healing within 2 days. And just to show you that these epidermal grafts are actually functioning, this is someone with piebaldism. So they had a vitelliginous-like skin on the white patch on their leg. We abraded it with sandpaper. I transferred those epidermal grafts onto that abraded skin. You could see that the skin took, and you could see over time it was producing melanin that helped to repigment that spot. So those grafts are alive. Those grafts are alive. Also, to demonstrate the idea that there's very little donor site morbidity, we used it in somebody with pyoderma gangrenosum, where you're very careful about doing grafting because of pathergy. But here's 8 days after the procedure. You can see where the hair was shaved, but there's no pathergy whatsoever. You can't even tell anything was done there other than the shaved area. And when we transferred those epidermal grafts onto this person's wound, this is someone who had been on prednisone, and presumably the inflammatory component was under control, but they needed some stimulation for wound healing. We put the epidermal grafts and they went on to heal. We use it in many different situations. This is someone who had venous insufficiency but had skin cancers removed. And instead of closing it, which would have been difficult in this older person, we decided to use these epidermal grafts. And we put the epidermal grafts here, and we looked at the wound, and I wasn't sure what's going on. It looked like the wound was, the edges were migrating across, but I wasn't sure if these were the grafts or they were just marks from the dressing, right? So I wasn't sure. So we just used dermoscopy. We put the dressing on top of the dermatoscope, and each one of those things are actually little grafts that take, and then that went on to heal. So a very simple procedure to help speed the healing of an elderly person with leg wounds after surgery. Now, so that's epidermal grafting. No scarring, epidermal grafting. But can you take full thickness skin and not leave a scar? So this is called fractional full thickness skin grafting. And it comes from the idea of fractional lasers. We know that when you have fractional lasers, you create these small holes, and when they heal without scarring. Not only do they heal without scarring, but as demonstrated in this picture of somebody having fractional lasers, you can't even tell that they had anything done in that area, even though full thickness wounds were created. They're used to treat scarring. But the concept is, if you created these holes, could you use that skin that you created? If you created small holes, could you use that skin and help to heal wounds and still have the donor site heal without any problems? So this is the idea, and this was the idea that was thought by Rox Anderson at Harvard. The idea is instead of creating a wound, can you pull out these little micro columns of skin? And in fact, you can. Here's the epidermis. Here's the dermis, and here's the fat, so a full thickness piece of skin. And then the concept is you could take that skin, pluck it down into the wound, have the full thickness skin with all the cytokines and growth factors and the tissue there that can lead to improved healing. And this is the donor side. Initially, there was this array that was linear, as in the prototype. You see that this is the treatment, and by 3 weeks, you barely can tell that there was full thickness wounds created there, healed virtually without scarring. And by histology, pretty good histologic findings of very little scarring, similar to the fractional laser. But the question is, does this speed healing? So this is a pig model. This is a full thickness wound in a pig. This is a full thickness wound in the pig treated with these micro columns. And you could see that there seems to be less wound contracture and faster healing. By 2 weeks, there's less wound contracture and healed wound compared to a non-healed wound. And you could see at 6 weeks, less wound contracture and compared to these. So there seems to be faster healing and less wound contracture when you use this in this experimental model. So this is the procedure. This is someone's thigh. This is the device that's currently available. It's called the ART, autologous regenerated tissue. You take donor skin. You have to use local anesthetic here. You take the donor skin from the person's thigh. And then this is, I think, hopefully you can see it. This is the wound that we're treating down here. Let's see if we can find it here. I'm not sure if this picture is turning out very well. But then what you can see here is you hit a button, and those full thickness columns spit onto the skin. I'm not sure if you can see that, but they spit onto the skin. And in this array, you can harvest 300 columns in 20 seconds with this device. Okay? And this is what the array looks like at the time of healing. There's very little donor site pain after you do the procedure, and this is a week later with virtually no healing and no scarring. You know, by 3 weeks, you don't know that there's anything been done there. And while there's initial donor site pain on a scale of 1 to 10, a few patients had pain. By day 2 or 4, virtually nobody had any more postoperative pain. There hasn't been a randomized controlled trial yet to show the benefit in patients, but this is somebody with 2 wounds. This side was treated with those fractional full-thickness skin grafts. Here, because you couldn't see them so well, they were colored so you could see them a little better. And then at 6 weeks, this side that was treated is completely healed, while the other side is still open and didn't heal for several weeks later. So again, in this experience, patients did better. In chronic wounds, this is a diabetic foot ulcer. The area in green was treated with these fractional full-thickness skin grafts, and you could see how that part healed while the rest of the wound remained unhealed. And here's for surgical wound healing. This is a Mohs defect. About half of the wound had healed by 2 weeks, and by 4 weeks completely healed, faster than what might be the clinical experience. And similarly, in somebody with a nose defect, complete healing, and actually what's thought to be a better cosmetic result in follow-up, perhaps because you're using full-thickness skin and getting less contracture, for example. Now, so that's the idea of creating a scarless donor site. Just before I move away from donor sites and skin grafting, I do want to talk about whether donor sites matter, the site of where you take the skin matters. And this is a patient with a non-healing wound. And what we did is we took punch grafts from different parts of the patient's body. One area we took them from the scalp that had hair follicles, and then we took it from the back that didn't really have hair follicles, and we treated one part with the grafts from hair follicles. We left a control in the middle, and the other side we treated with non-hair-bearing skin. And we found that there was better performance of the graft when you took the graft from hair follicles. Presumably, the follicular stem cells might be beneficial. Subsequent to that, Paco Jimenez from the Canary Islands did a similar study that we helped with. He took, again, hair-bearing skin versus non-hair-bearing skin. He treated one half of wounds with hair-bearing skin, the other with non-hair-bearing skin, and followed the healing and showed that grafts taken from hair-bearing skin, presumably with follicular stem cells, had better healing. And here you can see just a clinical example of the patient that was treated. And if you go from the top, where 50% of it was treated with scalp punch grafts versus abdominal punch grafts, you had a greater wound size reduction with the scalp punch graft. And this was over many, many patients. Okay. Moving on to the next question or pearl is, to close an extensively undermined surgical wound excision site, what would you do? Would you close both the deep tissue and the epidermis with sutures? Would you close the deep tissue only with sutures, or would you close the epidermis only with sutures? So the next pearl I want to share with you is, at least if you believe the literature, you can forget the epidermal sutures. Okay, let me show you some data. Data is about which suture matters and which suture techniques matter. Okay? So this is a series of kind of very nice studies. What they did was they took surgical excisions done by the same surgeon. Half of them they treated one way, and half of them they treated the other. So the patient was their own control, the surgeon was their own control, and they were able to evaluate different surgical techniques. And in the first studies, what they did was they did excisions, and they closed the whole wound with deep sutures. And then they compared half of the wound with cutaneous stitches and half with steri-strips. And what they found was that the steri-strip group was better at 2 weeks, but at 3 months and 6 months, no difference in cosmesis. So here's an example. This is at 2 weeks. Number 1 is the sutures. Number 2 is the steri-strips. I think you can see that the steri-strips look better. But then at 6 months, no difference. So comparing if you close the deep sutures and you put steri-strips versus sutures in the epidermis, no benefit of the sutures. So the next study was, again, they did surgical excisions, they put deep sutures in, and then half got steri-strips and half of the wound got nothing. All right? And again, no difference in healing. So steri-strips were equal to epidermal sutures, and doing nothing was equal to steri-strips. Okay? So if you look at that data, you'd suggest that doing nothing was equal to putting in cutaneous sutures from a healing and cosmetic standpoint. But you're going to tell me, no, I need to put epidermal stitches in because I want to evert the wounds. That's what I'm doing. I'm averting the wound edges. So the question is, does that suture technique matter? Does wound eversion improve cosmetic outcome? Because when you're doing surgery, you're tending to say, you got to avert the edges, you got to avert the edges. But is that really wives' tale, or is that true? Well, if you believe this paper and several papers like this, it's probably not true. So this was a study that they purposely averted the wound on half of the wound, and then just did a plain closure on the other half. And you could see that the wound eversion actually worked, but 3 months later, no difference in outcome. So the idea of averting the wound edges may not make a difference. No difference in height or depth across the patients. So if you're putting in the epidermal sutures to avert the wound edges in some way, shape, or form, you don't need to do that either. And some people, again, I have no interest in this dressing, financial interest or what have you, but this is a dressing that is something that was studied, and they looked at with and without epidermal sutures. So first of all, you have to close the dermis. You can't not close the dermis. If you don't close the dermis, then the thing will fall apart. But if you close the dermis, and in this case, because of the dressing, you couldn't do split side comparison. They just had groups of patients. But if you close the dermis and put this dressing on, you got very, very nice cosmetic outcomes and similar between the groups. So it was a small sample size, but there was no difference in cosmesis. And using kind of this steri-strip dressing, it was easier and faster to apply and remove. Okay. Moving on to the next pearl. So you plan to debride a wound, and when you're going to debride this wound or debride this wound, what are you trying to do? Are you going to remove wound tissue from the wound bed? Are you going to move tissue from the wound edge? Are you going to remove both? Or are you going to, I don't want to debride. So the pearl here is debride the edge. Don't forget to debride the edge. Because what happens is, in acute wounds, the edge is activated. There's cytokines and growth factors. You have epidermal migration, and it covers the wound. But in a chronic wound, this doesn't occur. What you have is a hyperproliferative, non-migratory edge, and so much so that histologically sometimes it looks like cancer. They call it pseudocarcinomatous or pseudoepitheliomatous hyperplasia. So it's hyperplastic but non-migratory. And what we've learned, some investigators at the University of Miami, is that there are certain factors that cause this edge to be hyperproliferative and non-migratory. And those factors are the presence of c-MYC and the factor that beta-catenin is in the nucleus and not the cytoplasm. Okay? Just as an example, if you have keratinocytes in culture that are migrating around, if you make them overexpress c-MYC or you make them express beta-catenin in their nucleus, they'll stop migrating. So these two factors are not only biomarkers, but important in the normal functioning of keratinocytes for epidermal migration. But what happens is, at the edge of the wound, these factors are present, as is the absence of epidermal stem cells. But if you move away from the edge, the cells become more normal. They no longer express c-MYC, and they no longer expect nuclear expression of beta-catenin, and they actually have a fair bit of epidermal stem cells. Okay? So the idea when you debride is not only do you want to debride the base of the wound that may have bacteria and slough and eschar, but you want to debride the edges to get from the non-healing phenotype to the healing phenotype. So you want to, and that you can see location B, which is farther away from the edge, is similar, even more epidermal stem cells than normal skin. And we looked at this. We did gene expression profiles looking at before and after debridement. And debridement actually reverses this, this fate of non-healing wounds, that if you debride farther enough out, you can take that cells that would normally not migrate and allow them to migrate. So the question is, how far do you go? Well, right now we're not entirely sure. What we do know, though, that if you had a molecular eye, you could see very clearly that here, on one half, you have a healing competent tissue. On the other half, you have, healing incompetent tissue. You have nuclear expression, for example, of beta-catenin. Here you have healing competent tissue. You have cytoplasmic expression of beta-catenin, no nuclear expression. And right over here, if you had a molecular eye, you could say, there's the line. And if you knew, you could cut right there and cut away the tissue that wasn't able to heal and get to the tissue that is able to heal. Okay? So we thought about a little bit almost like skin cancer surgery, Mohs surgery. When you cut away a skin cancer, whatever technique you use, what you do is you look at the edges, you look at the margins. Did we succeed? We set out to cut away the cancer. Did we succeed? We looked at the margins. So we suggest, and there are as many surgical debridements of wounds as there are skin cancer excisions in the United States. So it's a big, big, expensive procedure where it's not controlled. There's no evidence that you succeeded in doing what you set out to do. So the concept here is that you want to debride a wound and then check. In theory, you'd like to check to see, did I succeed or didn't I succeed? If I didn't succeed, then maybe I should debride again. If I did succeed, I know that I was successful. So this is kind of the concept. Now, there's other reasons to debride other than C, MYC, and beta-catenin. What you may not know is that when we normally think of bacteria, we think of them floating around kind of in the milieu. But what happens is, at the edge of chronic wounds, bacteria, and this is just Staph aureus, for example, hides in the keratinocytes. They hide in the keratinocytes. Now, normally, if bacteria tries to hide in your keratinocytes and you're healthy and normal, you kill them. How do you kill them? You kill them by something called perforin 2. Perforin 2, we recently described a few years ago, is the mechanism by which humans kill intracellular bacteria. It's very similar to complement 9, which kills extracellular bacteria, and perforin 1, which you may have heard of, which kills viruses. All three of these have been described by this fella, Eckhard Podak, who was just passed away a year or two ago, and he worked with our group to show that, that perforin 2 seems to be the critical mechanism in destroying intracellular bacteria. If you're deficient, if a mouse is deficient, for example, in perforin 2, simple bacteria will kill them, even if you apply it to the skin, because they don't have a defense mechanism. But interestingly enough, when we looked at the edge of chronic wound versus skin farther away, there seems to be a deficiency in localized deficiency in perforin 2 that allows bacteria to live in the keratinocytes and then repopulate the wound and cause infection. Okay? Which suggests perhaps there's a target for treating chronic wounds, that if we can kill the bacteria by upregulating or stimulating perforin 2 in these deficient areas, we can get to lead to better healing. Okay, a couple more vignettes as we head for home. A patient comes to your clinic for an excision of a cyst and learns his dog just died in the waiting room. So what do? Do you say, I'm sorry, lay down? Do you say, you just ignore the dog's death and proceed? Do you say, here, take this pill and proceed? Or do you say, you reschedule the procedure? Was that an opioid? No. Could be, no. So the right answer is you have to be wary to reduce stress, because stress impairs wound healing by as much as 40%. And they're beautiful experiments. I have college-age kids, so I love these experiments. They take kids who are going to college in the beginning of the semester and they wound them. They wound their palate. They're happy, they're having a good time, they're seeing their friends, and they heal beautifully. But then they take those same kids and wound them right around time finals. And they're stressed, they're studying, they heal 40% slower. So stress works by a number of different mechanisms, glucocorticoids and catecholamines. I'm going to focus on, just for the second, glucocorticoids. And what happens is you get stress, physiologic or psychologic stress, you secretion from the pituitary of adrenocorticotropic hormone, which causes the adrenal gland to release steroids and epinephrine. And what this does is it affects circulating cytokines. So the inflammatory cells at the site of the wound are reduced, and the pro-healing cytokines are reduced. And what happens is that worrying about surgery, patients that are depressed, patients that are negative, patients that are isolated, or those that experience more postoperative pain heal slower. So if your patient comes in and they're in a high-stress situation, that's a problem. On the other hand, if they patients who physically exercise or mentally exercise, if they have good attitudes, if they have more socially interactive, or if you control their pain, not with opioids, control their pain, they have less stress and they heal better. Okay? And it seems like many of these are mediated through the love hormone, oxytocin. So if you give oxytocin, in theory, you can reduce stress and speed healing. So as you go out in your everyday lives, and you want to try to create a stress-free environment for patients. You want to, if you can avoid performing procedures on stressed patients, reschedule them if they're elective procedures, and of course you want to make it as painless as possible to reduce stress. And again, you can get a 40% benefit in healing just by paying attention to these simple measures. And now I think this may be the last vignette as we head for home that I wanted to share with you. So after excision of a skin cancer on the leg, how would you take care of the wound? So would you use an occlusive dressing? Would you use Vaseline and non-stick dressing? Would you use compression bandages, or would you use 1 and 3? So the pearl I want to share with you is compression for leg wounds, including surgical sites. So in the absence of arterial insufficiency, if you have a wound on the leg, you should compress it, because compression treats gravity in addition to venous insufficiency. If you're not doing it, it'll change you and your patient's lives significantly. But before I get to compression, let's talk about occlusion first, because you should occlude as well. Okay? Why do you want to cover a wound or occlude it? Lots of studies. Faster healing, better healing, reduce pain. And one of the concerns for the last 50, 60, 70 years, that if you cover a wound, bacteria will grow and cause an infection. But the truth is that if you cover a wound, although bacteria might grow a little bit, you actually reduce infection, because you keep the bacteria from the outside world out and not let it contaminate the wound. So this is just an example of occlusion improving scars. Now, you probably have heard of silicone for scars. The reason why silicone works is because it causes occlusion and reduces inflammatory cytokines that occur in a wound, and it reduces that and leads to less scarring. So the idea here is that if you let a wound dry out, you'll get inflammatory cytokines and lead to scarring. But if you cover a wound, you'll get better healing, and not only that, but you'll get the epidermal thickness will be better as well. So this, taking what I told you about suturing and taking what I just told you about occlusion, you can put it together. Here's an example of somebody who had a wound that was excised. The wound was, the deep sutures were placed in. Half of the wound was sutured, the other half wasn't. We put an occlusive dressing on. When you take it off, you can see how beautiful that non-sutured half was. So by occluding it and not having to suture it, you can get very good healing equal to putting sutures in. Now, you're going to say, but what about ointments? Wasn't that this famous study in JAMA 20 years ago that said we should put Vaseline instead of antibiotic ointments on? What about that? And this was a famous study. It showed that in comparison to an antibacterial ointment, bacitracin, that Vaseline or petrolatum was equally good. So you go to clinic now, and instead of putting a bacitracin, maybe you're putting Vaseline on your wounds. Okay, so that's fine. But the question is, if you have this occlusive dressing, do you have to put Vaseline underneath it? Well, this is a study carried out a couple years ago in the British Journal of Dermatology, where they looked at wounds, and they used occlusive dressings with no ointment. They used a Vaseline, and they used an antimicrobial dressing, and they looked at different outcomes. And what they found was that there was no difference in infection rate if you just used an occlusive dressing versus Vaseline or an antimicrobial dressing. So if you put an occlusive dressing on, you don't have to put an ointment on. You don't have to put an ointment on. So applying ointment does not seem to be an additional benefit if using an occlusive dressing. Okay, so it's extra work. Now, let's get back to compression. So the pearl here is you want to compress anybody with a wound on their leg as long as there's good arterial flow. It's not just for venous disease. It treats gravity. It treats edema. In fact, if you have an edematous leg and a wound, just by compressing it, you'll reduce the number of bacteria. It's like mosquitoes in a swamp. Okay? You can kill the mosquitoes or drain the swamp. If you have an edematous leg, you can, by reducing the edema, you'll reduce the bacterial burden in that wound. And which of these legs would you prefer to operate on? So what we do is if somebody comes in here, we compress them, get them thinner, and then afterwards we compress them. So the classical indications are things like that, but to this we want to make sure that all wounds of the lower extremity, as long as there's good arterial flow, such as surgical wounds, should be compressed. Now as I finish, I just want to show you this picture here. Does anybody know the story of St. Peregrine? Okay, well, so it turns out that he, at age 60, he developed an infection in his leg, and he was told he needed an amputation. Now, in those days, they called an infection a cancer. So he was worried about it, so he prayed. He went home and prayed. And when the doctor showed up the next day to perform the amputation, that cancer, that infection was gone. Okay? And then he lived for another 25 years, despite having the day before having this infection that needed to be amputated. So as it turns out that God works in mysterious ways. If you look very closely at this picture, you see the angel, he's using compression. So that's why we compress all legs. It's God's work. We're doing God's work here. So in the last few seconds, I'm just going to tell you about some compression systems. Again, the standard ones are these wraps, Kerlix and Coban, which many of you may know. There's Coban 2, which is 2 layers. There's Pro 4. There's also support stockings. Support stockings are hard to get on, especially for older people, people who don't have strength in their fingers. So sometimes we recommend they get this thing called a stocking butler that may cost as little as $20. You put the stocking on this piece of metal, then you slip your leg on and pull the metal up, and it's very cheaper. Or you can get these gloves that give a 90-year-old woman the strength of Samson. You can get it at either a surgical supply store or at Home Depot. Okay? And then there are some other systems, these Velcro systems like Circade, that instead of wrapping the legs, they can use Velcro. And more recently, there are this compression system called CoolFlex, which we did some studies on, that use bra strap technology. So instead of having Velcro, you use the bra straps, and very easy to use. A bunch of people who were not able to tolerate stockings used this. Good results. Were able to tolerate it. Okay. So I'm going to stop here and just summarize what I told you in a relatively fast amount of time and then answer any questions. So the first pearl I told you was avoid opioids. Emerging data says not only are they bad, but they're bad for healing, and they're more widespread in dermatology use than you'd imagine. That there are now evolving techniques to have scarless donor sites, epidermal grafting, and this new fractional full-thickness skin grafting may allow you to use the power of autologous skin without having significant donor site morbidity. If you're brave, and it's hard to change our habits, it's really hard, but if you're brave, after you put dermal stitches in, think about forgetting the epidermal stitches. okay? In chronic wounds, you want to not only debride the base, but debride the edge, because the edge is non-migratory, hyperproliferative, and it harbors intracellular bacteria that we may have localized deficiency in getting rid of that bacteria. If you're doing procedures, whether they're aesthetic procedures, cosmetic procedures, try to create an environment that facilitates stress-free and reduce pain, because by reducing stress, you'll get better outcomes and can speed the healing as much as 40%. And then, in addition to compression, which you might have heard about for years, occlusion that you might have heard about years, don't forget to compress the legs, especially after surgical procedures on the legs, and you'll get reduced infections, reduced amounts of dehiscence, and better clinical outcomes. So I want to thank you very much for your attention, and I'm happy to answer any questions. Thank you very much. Yes, Scott.
Thank you. That was a great presentation. I've got a couple questions. If you do these, the epidermal grafting like that, and then it takes, if you were to go back 10 years later and look at those cells to try to determine if they were of donor site origin or the wound site origin, what would you find?
So it's not known. It's not known. It's an excellent question. It's a question that I've been curious about a long time because of this idea that skin grafting works by two mechanisms. One mechanism, which is the obvious one, is graft take. But the other one, which I highlighted briefly, was the idea that skin can also stimulate healing. And the question is, you put skin on, is it the local skin that eventually replaces it? If you use allogeneic skin, then it's clear, even though if you don't see it being lost, it's very clear that if you take allogeneic skin and put it onto a wound, the wound may never apparently reject it, but if you go sample that, then it's the recipient area. But so far people haven't done that study. The closest thing, well, they really haven't done that study. It would be nice to kind of label the cells in some way, shape, or form.
Yeah.
Yeah.
So my second question goes back to the allograft. If you have someone who's got huge burns or epidermolysis bullosa or some focal injury, could you use an allograft, epidermal allograft? Will that work? Will that hold?
Yeah, so what was very interesting is when they developed these epidermal allografts, okay, and they put them on burn patients.
Yes.
Okay, they would put them on, and then the wound would heal. And they said, well, geez, it should be rejected because they're non-self, right? So initially they said, well, maybe it's because the burn patients are immunosuppressed. And that allowed them to take. But then when they did the epidermal allografts and put them on, they would excise, for example, a tattoo, and put the epidermal allografts on a tattoo site in healthy people. Again, the epidermal allograft sat there, and the wound seemed to heal without the skin being rejected. But when they used sex mismatched donor and recipients, they took male donor and put on a recipient wound, and then looked for Y chromosome. They found that as soon as 1 week after grafting, if you sampled the skin, it was the recipient and not the donor site. Even though you didn't see it fall off, you didn't see it reject, it kind of sat there, and then kind of silently it was replaced by the recipient's own skin. So at least in allografts, it's replaced and replaced relatively quickly. Yeah.
This is a fantastic talk. So 3 questions, 2 quick, 1 a little more complicated. So first is yes or no, do you love Buddha boots? The second question is for the epidermal grafts, we're using a film dressing on top, so if you were, for example, to do a shave, you still like Tegaderm on top of that. So I'll let you do those first 2.
Okay, so yeah, so I love compression, and Una boots are fun. There's 2 different types of compression. There's elastic compression, where you take a bandage and it stretches more than 50% of its normal size. And when you put that on a patient, it squeezes the limb, whatever's going on, whether they're walking, whether they're resting. That's called active and passive compression, elastic compression, or long stretch. The Una boot is inelastic compression. It's short stretch. So if you pull it, it doesn't stretch very far. and you put it on, and it hardens, and it only compresses when the person walks. So when the person walks, their calf muscle hits against the hard Una boot and provides compression while they're walking. If they're just laying down, it's not squeezing the leg. It turns out that it's the Una boot and inelastic compression, short stretch compression, are safer for people with arterial insufficiency. Because what happens is, if I have some arterial insufficiency, I have the pumping of my heart, but if I'm standing, I have gravity to help the blood get to my toes. If I put elastic compression that squeezes all the time, and I have some arterial insufficiency, it's possible at night, when I put my leg up, and I lose the gravitational arterial propulsion, that I could cause ischemia. So for people with some degree of arterial insufficiency, Una boot is the preferred form of compression that one would use. So I love Una boot, sure.
And for the
And
grafts,
second,
the grafts you use.
It was developed with initially with a film dressing to transfer the grafts, but you can use any type of dressing that. So people have used other foam dressings that are a little bit more absorbent and things, and designed those. But the initial ones were with film dressing.
The final question, you brought up the issue of occlusion versus having some kind of a volume base. So when you say really true occlusion, you mean like a film or something that's very tight. A standard Band-Aid probably would not confer that same degree of occlusion. I think there was even one study showing that just putting petrolatum was equivalent to putting a Band-Aid with nothing on it. So I guess where do you draw the line in terms of something will be occlusive enough and that's sufficient versus needing something more hydrophobic plus something to keep it on top to get the same effect?
Yeah, so there haven't been a huge amount of studies, kind of comparing everyone. Yes, so a Band-Aid's better than air exposed, but is not as good as, so it's semi-occlusive. It's better to be completely occlusive for a variety of mechanisms. Yeah, and one of the important ones is that it keeps bacteria out. So certainly. Lots of studies have shown that if you put occlusive dressing on, it reduces the risk of infection of that wound, primarily by keeping the outside world out. Yeah.
Thank you so much. Another question about the epidermal grafting. You didn't have the device, that cool device, and you were just doing that bedside shave technique. I think you sort of answered the question a little bit. With aftercare, you use occlusive dressing. What about other practical things like, can you use lidocaine with epinephrine, not epinephrine preferred? How do you code or how do you bill for this procedure?
Okay, so you're talking about pinch grafting, or split thickness skin grafting, where you just numb up the donor side with local anesthetic. It turns out that even though there's a lot of data around catecholamines and wound healing and things like that, there seems to, the epinephrine is fine. So you can certainly use lidocaine with epinephrine, makes life a little bit easier so they don't bleed you, and you can see where it blanches, you know where they're numb, and then you shave it off, occlusive dressing on the donor side, and then you put it on the recipient side, and then either some steri strips or just a dressing to hold it in place, and then compression on top of it if you're treating a lower extremity wound. So it's coded as a split thickness skin graft. So it's the reimbursement actually is quite good. Yeah, quite simple, quite good.
Thanks, Dr. Kirsner. Thanks for the talk. I just had a question. You mentioned occlusive dressings plus or minus an ointment, whether it be petrolatum or vasopressin or mupirocin.
Yeah.
Again, from a practical perspective for pain control, when you're changing dressings, typically I've noticed when the dressing is adhesive that the patient will have more pain, and you need to either use saline or some other material to get that crust off because they have a lot of pain when the adhesive is being removed. So what do you think about that?
Yeah, so in theory, so when you put an occlusive dressing on, you take it off for two reasons. If it leaks or falls off. So you shouldn't remove an occlusive dressing like Q-Day. Leave it on as long as it stays. And then when it leaks or falls off, then it's easy to come off because now you have fluid or liquid there that makes it come off easy. When you do remove an occlusive dressing, never pull it back. What you want to do is you want to pull it out. That releases the adhesive, and then it doesn't hurt. So if you pull it back, like you pull off a Band-Aid, you don't want to do that. You want to stretch it out. The adhesive gets loose and then it comes off.
I was interested in the technique where you're talking about the suction blisters separating right there at the basement membrane.
Yeah.
And the device that you showed was kind of fenestrated, had all these.
Little microdomes, little holes, yeah.
Yes.
Yeah.
Is there a device that would actually take a larger area? And what I'm thinking about is melanoma in situ. If you believe it's truly in situ,
Right.
could you do that? Or warts, to just suction them off and create the blister there?
Yeah, so the answer is no. There's not, there's not a device to that.
Okay.
In theory, we don't know at what point, because that's done without any anesthesia, so we don't know if you took a larger blister would be painful or things like that. But in theory, you could do it, but there's not a device. The device that was developed, and the nice thing about devices is that you can get to the market pretty quickly. You know, a drug may take 20 years to develop. A device may take 2 or 3 years because the FDA approval process is much easier. So the people that made this, they wanted to get their device onto the market, and they did some little studies about maybe what size circles they should take, but they didn't do an extensive array and have a whole category. But if there was a market, the company is called Acelity. And you could contact them, and if you can convince them that they would, that there's a market, they could study whether different size devices might be worthwhile, for the things you suggest.
And then most of the pictures you showed were only partial the wound was partial thickness, just into the dermis somewhere. If you're a Mohs surgeon and you do a full thickness and you have a big hole with fat there, will these techniques work without a dermal substrate?
So I would say that traditionally people would say you want to graft on a well-granulated bed. But now with these scarless techniques, I think it gives you the freedom to do serial grafting, where you may take like these fractional full thickness grafts, you may put them into the wound and let the first dose of those grafts build the granulation tissue. And then you might come back and put a second graft, whether then it's another fractional full thickness graft or an epidermal graft, and you can do a staged procedure, one to improve the granulation tissue and the other to get epithelialization. Those studies, because both of these techniques are relatively new, the sweet spot hasn't been found out yet, but in theory you can take some of these ideas and figure out what's going to be best at the right time.
Yeah. And my final question, with TEN patients,
yes.
Do you debride those patients, and have you tried this technique with them?
No and no. So we don't. The difference. One of the differences between going to the burn unit and going to the dermatology, on the dermatology control, is we do not debride TEN patients. They do debridement. We think we do better without debriding, so I think that there have been some small burn patients that have been treated with these epidermal grafting, but I think for TN it's just too widespread, to use these techniques. Yeah. Well, thank you very much for your attention. It was great to spend time with you.